There are two main procedures for women doing IVF. First is the egg retrieval, which we recently discussed on another Lunchtime Live. And the second one is what we're talking about today. Dr. David Schmidt is back with us on Lunchtime Live at the center to talk all about embryo transfers, what they are, what to know, and how to prepare for them. Dr. Schmidt, great to see you again.
Thank you. Nice to see you as well, Ami.
What is an embryo transfer? We'll start with that.
Great question. A lot of people have anxiety about this if they haven't been through the IVF process before. And we've already discussed the methods of ovarian stimulation, the process of the egg retrieval. And unlike the egg retrieval, which is done, of course, under anesthesia because it's a minor surgical procedure, the embryo transfer does not require any anesthesia, and it's a very delicate transfer with a sterile catheter while the patient is awake.
Okay. So you are returning the embryos back into the woman. Where does the catheter go?
Right. So once we've cultured the embryos out to, and that's a common question as well, when do we transfer the embryos? Each patient's physician will talk to them specifically about recommendations based on what treatment they've had. But for the most part, embryos are transferred on day 5, or what we call the blastocyst stage of embryo development. And this is a stage where the embryo has, fertilized and developed after fertilization through the multicellular stage or day 3 embryo out to the blastocyst stage or day 5 embryo. So embryos can be transferred here at day 3, which we've done for decades with the inception of IVF. And over the last decade, blastocyst transfer or day 5 transfer has become preferred. So if a patient is having a fresh transfer, and that's what we refer to it as, a fresh transfer, it would be transferred in the same cycle that they were stimulated, and this would be done 5 days after their egg retrieval. And then because it doesn't require any anesthesia, our patients would come into the same procedure area on our first floor where the egg retrieval was done. It's actually done in the same sterile procedure room where the egg retrievals were performed, and they're done every day. They usually follow after the egg retrieval procedures are done. Our transfers are done in that same sterile room because it's attached to our IVF lab where the embryos are being cultured. And it's a very simple process. A very soft catheter is used to transfer the embryo, and basically it's glided through the opening of the cervix up into the uterus. This is actually a uterine model with abnormalities, but we would not be transferring an embryo if any of those were discovered. So here's a diagram of a normal uterus, and the natural opening of the cervix is accessed with a sterile catheter, a very soft catheter, and the embryo is floated in the center of the uterus. So many people ask, does this hurt? Is it crampy? It's actually, if for those patients who have already undergone intrauterine inseminations, I would refer to this as a more gentle insemination. So you can be awake. You actually can watch on the ultrasound screen. We do this under ultrasound guidance. And the catheter is a sterile catheter, just like just like our insemination catheters. This is a sterile catheter that has a softer inner insert compared to our insemination catheters. And that is required because the embryo transfer has to be very gentle.
Now, you mentioned it's done on day 5. That's not cycle day 5. That's day 5. So day 0 is that when you do the retrieval, if it was a fresh transfer?
I'm glad you clarified that, because we do tend to denote cycle days or stimulation days, cycle day 1, 2, 3, 4. But once we retrieve the eggs, then we refer to it as, and the patients don't need to know this, but it is 5 days after the eggs are retrieved. And so we refer to that as post retrieval dates at that point. Oh, there's a patient writing in. Thank you, Dr. Schmidt. You're welcome. I don't know if we can say patients' names, but that's a patient of mine. You're welcome.
Hey, Megan.
And she's thanking you as well.
Oh. So when it
Yes,
comes to a person's cycle, like say if they're having a frozen embryo transfer, how would they know when they would have a transfer?
that's excellent. And so that you bring up another great question. There are some people that are not going to have a fresh transfer, either that they have extra embryos that were frozen previously from a fresh IVF cycle, or if they did genetic testing on the embryos, which requires that we biopsy the embryos and then freeze them and transfer them at a later date. So if you're having a frozen embryo transfer, the process that I described, and we can get into more detail about that, how we do it and exactly what steps are taken. But the process is identical and regardless of when a patient's having a transfer. Now, in the case of a frozen transfer cycle, there are two main ways that we can do that. Either way, the embryo has to be floated into the uterine cavity at the proper time, or what we refer to as the implantation window. And that is typically 5 days after a woman ovulates, or because the embryo after fertilization, usually in a natural conception, the egg is released at the time of ovulation. It gets picked up by this area of the fallopian tube. Sperm travels up into the upper genital tract, out into the ends of the fallopian tube, where fertilization happens in the first 12 to 24 hours. Then the embryo develops as it travels through the tube, reaching an 8-cell stage here, and eventually a morula and a blastocyst, which is that day 5 embryo that we transfer. So we are mimicking transfer of the embryo at the identical time that embryo would be coming into the uterine cavity for implantation. And then implantation happens within the next 12 to 24 hours. So sorry, I shouldn't have eaten lunch right before lunchtime live. They should say pre-lunch, lunchtime live.
All right, next time.
But the implantation then would occur during this implantation window, and it can happen in a natural cycle. And your physician, each patient's physician will talk to them on what is best and what they recommend. Both of these protocols that I'm about to describe have equal success rates, but there's some minor advantages and disadvantages to each. But in a natural cycle, if a woman has regular ovulation, we can basically do some ultrasound monitoring and blood work to determine if the lining is thick enough and if a woman is about to ovulate. And then with blood work, we determine the precise surge when a woman is about to ovulate. And those are those blood tests that we check. Now, sometimes you can do urine kits at home, but for an embryo transfer, we want to be very precise and know that exact LH surge and when it falls, so we can determine this best implantation window. So that is how we would monitor a patient for when she's ovulating, for the determination of the best time of transfer, if it's a natural cycle and regular ovulation. I'm getting love, Dr. Schmidt. Miss him and all the center staff. Thank you, Nicole. I can say names, right? People, this is all on there. All right. So that's one way to do it in the natural cycle. For some women, they may be in menopause. They may not ovulate on a regular basis, or just for convenience factor, some patients want to know the exact dates of a cycle. So there is an alternate thaw transfer protocol, which we call a medicated cycle, where we take over control of a woman's menstrual cycle with low-dose Lupron injections. And without getting into too much detail, I can go into more of it if we need to. We basically turn off the ovaries and suppress them, and a woman would get her menses. And this is a cutaway view of the endometrial lining. And with menses day 1, we then bring the patient into the office, do an ultrasound, and then we take over development of the lining. And
Ah,
this is much more simplified than the process of a fresh IVF cycle. We're really just giving estrogen patches, one every other day, then we go up to two, then we go up to four. And what we're doing is we're recreating this ideal menstrual cycle lining to prepare the embryo for transfer. And then there's really only one ultrasound here, one 12 days into the cycle to make sure the lining's thick, and separated by 4 days apart, two estrogen levels, just to make sure the hormone levels are appropriate. And then we start progesterone here. And again, 5 days later, we're mimicking a perfect cycle. The Lupron prevents a woman from ovulating naturally, but we're have everything controlled with the start of progesterone, which mimics ovulation, prepares the lining for implantation, and 5 days later we schedule the transfer.
excellent. So if someone is doing a frozen natural cycle, when would they start to do the blood work so that you become aware of when they're going to
The
have the transfer?
in the case of the fresh cycle, we actually have to do the ultrasound. No monitoring really needs to occur before day 10 of a cycle, and
Okay.
then we get that's at a point where a woman who has regular ovulatory cycles should be at least close to ovulation, maybe here. So we don't want to do unnecessary monitoring if it's not needed, but we also don't want to miss ovulation. So usually about day 10, there's one ultrasound and blood work. If that person's not ready for ovulation and we need to get a little bit further along, we can do maybe one more ultrasound 2 or 3 days later, and then
Mhm.
we just check blood each day. Now, that's one of the downsides to the natural cycle. We're at the mercy of a woman's menstrual cycle in terms of when she's going to ovulate, how many days of blood work. We do have to do daily blood work when we're close to ovulation because we don't want to be off by a day. So, on the one hand, the natural cycle does require daily blood work, but we try to be strategic about that and do that only at the time of ovulation. So,
Okay.
that would require an ultrasound on day 10, maybe day 12 or 13, then blood, typically 3 days in a row, blood, blood, blood. And
Okay.
then we determine and call the patient and instruct them to start progesterone at the right time and come in for a transfer, 5 days later.
Okay. So when it comes to the transfer, who it's done in Farmington, you mentioned that. Who performs the transfer?
Right. That's an excellent question. So we although we have satellite offices, our IVF lab is only here at our Farmington office. So all the IVF procedures are done here, but we are open every day of the year and on weekends and as well, so that we don't have to shut down and we can allow patients to cycle year round. Occasionally we close the lab between Christmas and New Year's just for maintenance, but we slow down the cycles just that one time each year. Um, so the embryo transfers are done here by our physicians. We do have on a rotational basis, it's one of the attending physicians each day covering the IVF procedures. But each patient's doctor will always oversee their care, dictate their care, unlike
Mhm.
many centers where maybe just the doc of the day makes all the decisions. We each patient is assigned to a physician, and that physician is always overseeing their care, making decisions, talking to the lab. And although we have to, for logistics, we have to have a physician covering procedures each day because we can't be doing surgery and seeing patients and covering IVF procedures. Um, that physician in charge of procedures that day is in touch with each patient's physician in terms of any difficult transfer technique or a catheter
Mm.
that's supposed to be used or any pertinent history that might be important for success.
Okay. And do they need to come in with a full bladder? Are there meds given? And how do they know
Excellent.
when they'll come in as far as time of day?
Excellent. So the Unlike the vaginal ultrasounds that are done routinely during the stimulation, because it's hard to see the ovaries and the follicles with an abdominal ultrasound. When we're doing the embryo transfer, we have to gently place a sterile speculum to access the opening of the cervix. And we're transferring the embryo through that cervical opening. So we cannot do a vaginal ultrasound at the same time.
Mm.
So we do like to watch the embryo transfer to make sure it's going in to the uterine cavity in the proper area. So instead, ignore these surgical instruments, but this is a side view. If you can imagine the speculum being placed, actually, here it is.
I love the props.
That the speculum is placed and we glide this sterile catheter gently into the uterus. We have an abdominal probe ultrasound watching the catheter come in, and we can show the patient the little bright white spot that represents the fluid with the embryo going into the uterus, or embryos. If that's another question, how many embryos do we transfer? Over the last decade, we've been able to transfer fewer, higher quality embryos. And certainly in our younger patients, it's only ever one. Current guidelines do allow for more than one embryo in certain age patients or certain circumstances, but it's a lot less than what we've done years ago. So lower risk of multiples. But nonetheless, the embryo or embryos are transferred in that catheter, and the ultrasound is done abdominally. But in order to see through that tissue, the bowel and into the uterus, through the stomach, a full bladder filled with fluid allows these ultrasound waves to pass more readily through the full bladder and see the uterus more clearly. And think about, back to high school science or whatnot, sound waves travel more easily through water than air. Think of like dolphins that can talk, 20 miles away to other dolphins. And so it's similar with medical ultrasound. Those are ultrasound waves, and they pass more readily through fluid, which shows up as black or clear on ultrasound, versus bone and air and fatty tissue and muscle all block those ultrasound waves and make it harder to see. The last benefit, I know Ami's like, oh, wait, we're over time.
It's good stuff.
The next benefit of a full bladder is many women have, if they're laying flat, the uterus tilts upward a little bit. And that's fine. Some women have a retroverted uterus, and there's different curves. That's one of the reasons why we do a practice, or what we call a trial transfer, before a patient is coming in for the actual transfer, so that we can map the direction, the curves, what depth to place the embryo. And so all of this is set up ahead of time. Same with the medications. You asked about medications. There are no specific medications that need to be taken on the transfer day, specific for the transfer itself. But it is important for the patient to stay on her supportive hormone medications, either estrogen or progesterone, to sustain the pregnancy. When we do the transfer, although we have everything mapped out as far as the depth and the curve and the angle of the catheter, many women have a tilted uterus like this. And when you have a full bladder, if you look closely, this is the bladder empty, and this is the bowel, and the uterus is tilted forward. If this bladder is full, and we not only can we see more clearly through the fluid, the urine filled bladder, but the full bladder actually pushes on the top of the uterus, and it actually straightens the uterus out in line with the vaginal canal. So then we get pretty much a straight pathway and a much easier transfer. So the full bladder, we don't want patients to be extremely uncomfortable, but it is an important aspect of the transfer, and it will improve the success rates if it's easier for us to transfer.
Okay, so full bladder, there are not necessarily any medications given on the day of, right?
I have a fan club.
I know. Look at you.
All this. Thank you. You're all wonderful.
And does somebody need to bring the person in Do they need a ride home? What's the recovery?
That's a great question. The short answer is the egg retrieval, which requires anesthesia, that always requires somebody to bring the patient to the procedure and home, because when you have anesthesia, you cannot drive
Hmm.
or work or operate any heavy machinery or make any life-altering decisions. There are rare occasions where we do recommend anesthesia for the transfer. So if that were the case, same rules would apply. You'd need a ride. Most 99% of embryo transfers, however, are done while the patient's awake. And they're, as I mentioned, they're more gentle than an insemination. It's a softer catheter. And so there is no anesthesia, and a patient could drive herself home afterward. Now, because it's a delicate embryo transfer and it's the final stage for all this treatment, we do like patients to rest and take it easy when they get home, not doing
Okay.
any heavy lifting, no intercourse, no physical exertion or exercise. And, you know, is driving stressful and you're in an upright position, it's probably fine. But if you can get a ride, you might be able to recline a little bit and relax and just be less stressed driving home. That would be ideal. That's what we recommend, but it's not a requirement. The other
And
the other information that we have about that is we used to require patients laying flat for 40 minutes with their head down after a transfer, only because reproductive endocrinology centers around the world thought that that would result in better pregnancy rates. Studies have now shown that bed rest after transfer does not make any difference. So,
mm,
although we don't want you bungee jumping or lifting things, and no intercourse or pressure on the cervix, you can drive, you can walk around. We still tend to recommend, if you can get a ride and if you can be up off your feet that day, just that day, that
hmm
would be that would be best. But no longer is bed rest required.
And is there any limitation to intercourse prior to transfer and post transfer after the day
The
pass?
intercourse is fine. The only reason we recommend no intercourse after the transfer is if the prostaglandins from sperm can cause uterine contractions,
Mm,
or intercourse, can cause pressure on the cervix, and we don't have any scientific evidence to say that it alters implantation rates, but we don't want to take a chance just because so much has gone into this treatment. Intercourse before treat a transfer is okay unless a woman's doing a natural transfer and they're ovulating on their own. We
mm,
usually recommend couples avoid intercourse because we don't want a couple to get pregnant spontaneously with intercourse and with the embryo or embryos that we're putting in. One, it could result in unnecessary or unintended multiples, and or even women that are transferring one genetically normal embryo. If you conceive spontaneously, there have been case reports, not at our center but around the world, where a woman or a couple might have conceived and they put in a normal embryo, but that one didn't take, and then they got pregnant with an abnormal embryo and had a trisomy 21 or
mm.
pregnancy loss. So remember, although patients are usually doing this treatment because it's difficult to conceive, in many cases it is still possible to conceive. And so we have couples avoid intercourse right around the time of ovulation and once we do the transfer.
Okay. So there is a question at this time, can spouses be with patients during the transfer or at the time of the transfer?
That's a great question. All of our policies are under the state Department of Public Health and for surgery centers. So the pandemic, we couldn't allow anybody in the building, and now we have partners. Not only can they come into the building, they can come up for ultrasounds, clinic visits. They still have to obviously be well, and if you're ill, let us know. We still require mask wearing for all of our patients, within 6 feet of each other.
Mm,
I have my mask off, but I'm in a closed room. it's much better than doing it this way, right?
Right.
Um, but the unfortunately, the sterile operating room, which we're considered a surgery center, anesthesia requirements don't allow for partners or family members or significant others to come into the PACU or the surgery room. The surgery room itself has never allowed family members ever. Same with hospitals. That's like a surgery in an operating room. That's not allowed.
Right.
We used to allow spouses, significant others in the recovery area, but unfortunately, that is the same area where patients that are having egg retrievals procedures are going in, and anesthesia guidelines can't allow for family members, which in theory could be spreading COVID variants to other people. So
Okay.
they can and are encouraged to come into our waiting room, which is right on the other outside, right behind that wall is where we are. We can talk to family members. We can come out or go into a side room, and they can come in to the building, but just not into the actual procedure center.
Okay. And can children for appointments come to the appointments if a patient has additional children?
Yeah, yep. That's
Excellent.
now that's allowed. That wasn't allowed during the pandemic, but I just had a patient bring her little daughter in the hallway, and I got to see her. She's much cuter in person, although the picture was very cute, 100 times better in person.
All right, final question. What happens after transfer? When would a patient test for pregnancy?
Oh yeah, you're reading some of these questions, right? So after transfer, and I think I hopefully I answered Megan's question.
Hmm.
So family and children and significant others come into the building, and in the recovery area, if we need to talk to them, the physician can step out. But anesthesia isn't allowing the OR. Nobody's ever been allowed in that area, but the PACU used to allow significant others, but right now still we're under COVID guidelines, and they have to be in the waiting room.
Mm,
So to answer the question, after transfer, we do a pregnancy test as soon as we know it would be positive. It depends on the day that the embryo was transferred. The easiest way to think of it is about 14 days after a woman ovulates, you would know that would be when somebody would get their menses if they're not pregnant. So 14 days after ovulation or after the egg retrieval is when we do a pregnancy test for a fresh transfer. And that applies, what that turns out to be is if we're transferring a day 3 embryo, it's 11 days after the day 3 transfer.
okay.
Or if we do a day 5 transfer, it's earlier. It's at the same time in regards to embryo development, but 9 days after a day 5 transfer, which is the most common date of transfer, we would do the pregnancy test 9 days later. But I mentioned both because occasionally we're transferring embryos at day 3 that you would have to wait the full 11 days after
Okay.
transfer. But most people are doing a day 5 transfer. 9 days later, we will know. Your physician may or may not want to check some hormone levels in between the transfer and the pregnancy test. Now, if they don't do it, it's not needed. I don't want people to think that everybody's supposed to get it. Why didn't my doctor get that? There are certain protocols where you need to check hormone levels between, but many of them can just check a pregnancy test 9 days later.
Awesome. Awesome. Well, you've got some great great fans here on here today. Lots of children.
Thanks for the twins, Dr. Schmidt. Thank God
You
you
made
wanted
dreams come
twins.
true. Well, thank you for being here. It's always a pleasure speaking with you, and thank you for
Oh,
your time and the visuals. Those are great visuals.
oh, thank you. It was my pleasure. Hopefully, everybody got an understanding of what the transfers are like. If you have any other questions, please call us. If you're a patient here already, certainly call your physician or the nurse on the team, and we'll get you the information you need.
Wonderful. Well, be sure to check out our website or call us. Our website is yukonfertility.com if you need additional information, and we will see you next time for Lunchtime Live at the Center. Bye for now.